the Department of Center for Diabetes and Metabolic Diseases, Delhi Heart and Lung Institute. I am past chairman of RSSDI Delhi State. SGLT2 inhibitors are now in the front line in the management of diabetes because of their metabolic and cardiorenal protective effects. Two trials have come up in diabetic as well as non-diabetic patients, in patients with heart failure with reduced ejection fraction, DAPA-HF with dapagliflozin and Emperor reduced with empagliflozin. DAPA trial has shown, DAPA-HF, that there was reduction in dual co-primary endpoints as cardiovascular mortality or hospitalization due to heart failure by 26%, while Emperor reduced showed that it was 25%. So both the trials have shown almost the same effects. Then cardiovascular mortality was reduced by 18% in DAPA-HF trial, while it was reduced by 8% in Emperor reduced trial. But at the same time, we should see to it that in DAPA-HF trial, the risk or the cardiovascular risk in the patients was much less than Emperor reduced. Or we can say that in Emperor reduced, the cardiovascular risk was high at the baseline, and more patients used ARNI as well as devices for cardiac problem. And other important thing was ejection fraction was also low, the baseline ejection fraction in Emperor reduced. So we should not compare these two trials, and there is a heterogeneity because in the previous trials, EMPA-REG showed that the empagliflozin reduced cardiovascular mortality much more than other agents. So overall, the trials have shown that SGLT2 inhibitors, empagliflozin and dapagliflozin, both reduce the risk of future hospitalization to heart failure, the first hospitalization to heart failure, and cardiovascular mortality in patients who are diabetic or non-diabetic with reduced ejection fraction, that is ejection fraction less than 40%. So overall, SGLT2 inhibitors have come on the forefront in non-diabetic patients also with reduced ejection fraction, even if they have normoglycemia. As per AAC, as well as ACC 2021 guidelines, now SGLT2 inhibitors are placed parallel to ARNI, and they have been found even useful in patients with preserved ejection fraction. So the bottom line is that if a patient comes to us with diabetes, especially in India, besides lifestyle modification and metformin, I think from day one, we can start a combination of metformin and SGLT2 inhibitors, not only to achieve better A1C results, but more than that, to have beneficial metabolic effects and protective cardiorenal effects. Thank you.